And also it's very safe for the eye. It does not require any damaging. It's not invasive, so non-invasive method, and it's imaging diagnostics of the eye. What we can see, I'm not going to talk about how the ultrasound works. It's the same for every specialty. We have a little bit different transducers, and we can visualize the soft tissues in the eye. We have two modes, A mode and B mode. So in B mode, which is more important for some diseases, we can visualize the eye as a two-dimensional image based on reflectance of the structures of the eye. So here you can see the eye. You can see this darker spot is the optic nerve, which is always good to see when you're doing ultrasound, so that you can know where exactly your probe is pointed. So we have the pulse echo technology, where we have pulses, and this generates acoustic waves. They are sent in towards the eye, and then they are reflected, they are detected, they are amplified, they are processed, and then we have this visual picture that we get into the A mode. Is the other ultrasound that we like to use. It's a very it looks very simple. We get a linear scan of the area that we are testing. So usually in A mode, what we do, what we get as peaks, this is the cornea. So we have the reflectivity from the cornea, anterior lens surface, posterior lens capsule, and then we have this drop from the vitreous cavity, which is with low reflectivity, and then we have the retina, which has a high peak, and then slowly lowering the line. How we do the A scan? We have two ways of doing the A scan. One is contact. So we touch the eye with the probe, and this is what we usually do because it's less time consuming. And then we get the peaks from the cornea, the lens, and the retina. We usually use a scan for measuring axial length of the eye, measuring lens thickness, anterior chamber thickness. This is important for especially for intraocular lens calculations. Especially in eyes that have very thick cataracts, usually we don't get good results with more modern methods, like we have IOL Master, which is based on the OCT technology, but for very dense cataracts it does not work well because the lens is not transparent enough. And then we use this one. The other way we can do a scan is to put the immersion technique, where we put a chamber on top of the cornea, fill it with fluid, and then we put the probe inside the fluid, which is more accurate for measurements because it's a little bit dependent on technique, on experience, if you will push the cornea with your contact method. So if you're not that experienced, you will push the cornea more, and then you will get the wrong axial length. And if you use the immersion technique, there is less risk of pushing the cornea and flattening it. So here is the way the A scan probe looks. It's very small and it has a little beam here. This is the part that we touch to the cornea, and this is the B scan probe. It's slightly bigger. And it has a marker so that you know where to point the probe. What are the indications? You have to remember that the indication for ultrasound is basically non-transparent ocular structures. So if you have glaucoma, for example, which is a very thick vascularization of the cornea, you cannot see behind it. So then you can use ultrasound to check if the retina is okay, if the optic nerve is okay, and also if you have any pathology of the retina and vitreous. And if everything is okay, for example, and you have a non-transparent cornea, you can be sure that if you do, for example, some kind of corneal transplantation, then you have a good visual result post-operatively. In thick cataracts, as I said, you have to use either the A probe and B probe. A probe to measure the power of the intraocular lens that you want to implant, and also to B probe to see if the posterior segment is intact. And again, you will know what the result of operation for cataract will be. Hemophthalmos, this is blood in the vitreous cavity. So if you have this condition, you have to operate this as well, or at least treat it for a given period of time conservatively with the different medications. And if it does not resolve, then you go to surgical treatment. Also, solid tissue diagnostics. This is really important when it comes to intraocular tumors, cysts, and stuff like that. So if you have cysts of the posterior part of the iris, and also if you have cysts in the ciliary body, you can use ultrasound to visualize these cysts. And also posterior segment tumors, which is really important because melanoma, malignant melanoma, is one of the most common primary intraocular tumors. And you have to be sure that this is a melanoma because treatment is very aggressive. B ultrasound also helps us detect retinal detachment, and also if you have retinal detachment, you can determine what type it is. If it's tractional, which is typical of diabetes, you will see a figure called tent, like a tent, or a tabletop, and then you will know what to do when it comes to surgical treatment. Intraocular foreign bodies is also a very important indication, especially in metallic intraocular, but also non-metallic intraocular foreign bodies, because, for example, we cannot do an MRI on a magnetic metallic intraocular foreign body. So ultrasound helps us locate the foreign body and also check if it's with high density like metallic objects or low density, for example, from biological stuff like plants or other, for example, wooden particles and others. And as we said, a scan is used for measurements of axial length and lens thickness. So here we have a few B ultrasounds. So here we have traction from the vitreous on the retina with some edema and exudate. And also this here is something very typical. So this is a foreign body. My pointer is not that visible, but the whitish part here is a foreign body. And how do we know it is? We have these low echogenicity behind it. These are called reverberations, and this is typical of foreign bodies. So we have to operate and remove it, as well as remove the vitreous, as well as do some peeling on the retina to avoid complications and save the eye. Here we have something very important. So we have a tumor inside the eye. And here we combine B ultrasound with A ultrasound. So this is very important because malignant melanoma has low internal reflectivity. And when we see the peaks, we see that we have this plateau of the tumor. And also we have a vitreous detachment here, posterior vitreous detachment. Next to it, this is important to see if a tumor has a capsule, if it has certain characteristics that are typical for either malignant or benign tumors. And also important is measuring the mass. Here is a big melanoma that we can measure in dimensions, which is important because big tumors have a high risk of metastasis, higher risk of metastasis. Let's talk about fluorescein and geography. This is something that we do a lot. This is very important because most of the socially important diseases need to have some kind of imaging of the vessels because we need to determine if we have new vessels in the eye, and especially in the retina, because new vessels in the retina are detrimental to visual acuity. They are bad. We don't want them. So what we do is use fluorescein. This is a water-soluble molecule that has the property of fluorescence when it's activated by a certain wavelength of light. We then detect the reflected light. We transfer it through a filter, and then we get this image. So what we need to know is if we have, for example, this is a diabetic eye on the right. We have microaneurysms. We have this is a really relatively good diabetic eye. So what we do, we have aneurysms, a little bit of exudates, a little bit of leakage. We will stop and talk about each of these pathological changes. And here, the dark spots in the retina on the left eye, this is a hemorrhage that blocks the normal light from the vessels underneath. So we have some kind of new vascularization, some kind of reason that there is bleeding. There is bleeding from some kind of pathology. So this is the principle. As I said, we stimulate the molecule with a certain wavelength. And then when this molecule, it becomes excited, and then when going to a normal state, it emits light with a different wavelength. Fluorescein absorbs light in the blue range, so from 465 to 490. Sorry. And then it emits light in the yellow-green range from 520 to 530. This is what happens. Blue is the excitation, green is the emission. This is the principle. As I said, we have a white light source, we have a blue filter that sends only blue light in the eye. We excite the fluorescein, then we detect the reflected light with a filter, yellow-green filter, and then we get the image on a camera. It's, as I said, it's a water-soluble solution with certain concentration around 10%. We inject it in the antecubital vein, usually, or whatever vein is possible to get, because especially in diabetes, patients have um, very difficult veins to insert the cannula in. Then we inject the dye. I usually inject it slower, around 7 seconds, because if you inject it too quickly and the patient feels discomfort, they can start feeling nauseous or even have a syncope and pass out. Of course, the dye is excreted through the kidneys mainly because it's water soluble. And this is important. What are the phases? So first we have around 10 seconds. Usually this is for healthy young persons. We have 10 seconds for the dye to get from the vein to the retina. And then first the choroid is filled in because it's supplied by the short posterior ciliary arteries, which are the first branches of the ophthalmic artery, and that's why the choroid fills in first. Around 10 to 15 seconds after the injection. Then we have arterial phase, which is filling of the arteries. This is around 1 or 2 seconds after the choroidal phase. We have arteriovenous phase. This is when we have filling of the capillary bed of the eye. Then the dye transfers to the veins. Then we have a recirculation phase when we have equal distribution of the dye in the arterial and venous blood. And then we have the late tissue phase, which is around 10 minutes after injection, which is when we don't have any more dye coming in from the arteries and the eye starts to lose fluorescence. So here are the phases. We have this eye, then we have the choroidal phase, the arteriovenous. This is a red-free. This is a different type of imaging method. I will show you in the seminar a picture comparing all of our imaging techniques with the fundus camera. We have the venous phase, the recirculation phase, and the late tissue phase. What are the indications for fluorescein? They are very vast. All vascular disorders of the retina and choroid are indications for doing the angiogram. Macular disorders, for example, one of the most common is the macular degeneration, age-related macular degeneration, also tumors of the retina, vascular malformations. This is very important for children, and of course optic nerve diseases as well. They are indications for fluorescein angiography. What are the contraindications? The absolute contraindications are allergy, and history of adverse reactions in the past. The relative contraindications are allergic diseases, asthma, hay fever, also renal failure. It's a relative contraindication because we can adjust our dosage to get an image and spare the renal function. And pregnancy is also a relative contraindication. We do fluorescein angiography only if it is really necessary in pregnant women, especially usually these are pregnant women with diabetes that have diabetic retinopathy, and to, for example, point our treatments, we would need fluorescein angiography. This is a picture of a classical choroidal neovascularization. This is seen in wet age-related macular degeneration with filling and leakage of the new blood vessels that are formed in this area, in the macula. A very interesting disease is central serous retinopathy. This is the complete name of the disease. This is a very strange disease that we don't still know what causes it, but what we see is a serous buildup of fluid underneath the retina. So this fluid here is the same as so in the OCT scan, the dark zone is the serous fluid, and on the angiogram, this space fills up with fluorescein, and it begins to emit more light, and this is called hyperfluorescence. Here is an example of cystoid macular edema. This is, for example, seen in diabetic patients, and this is the most common cause of loss of visual acuity in diabetes is macular edema. But we can see macular edema after cataract surgery. We can see macular edema in uveitis as well. And this is the typical pattern, like a little flower, petaloid pattern of hyperfluorescence in the macula. So what we call the OCT optical biopsy because we get all the layers of the retina, we can see them, and especially with newer generations, we can get not only retina but also choroid in great detail. So the new generation of OCTs, they get more than 100,000 scans per second, which gives us a high quality of the images that we get. So what we have is we pass light. It's similar to ultrasound, but it does not use ultrasound waves, but light. So we get light inside the eye, and inside the OCT machine we have something that's called a beam splitter. So the light that goes into the eye is split, and it goes to a mirror, and then the light is reflected back from the mirror and back from the eye. The machine compares the two reflectances and does a mathematical calculation, which after that is translated to an image, 2D image. Here is the layers that we see, all the layers of the retina, which actually are more than 10, especially on OCT. So we get the choroid, the Bruch's membrane, the pigment epithelium. Then we get a very interesting part. So we have the outer segments of the photoreceptors, inner segments of the photoreceptors, the middle part of the photoreceptors where they have accumulation of organelles, which also gives us a hyper-reflective layer. Inward we go to the external limiting membrane, the outer nuclear layer, outer plexiform, inner nuclear, inner plexiform layers. Then we have the ganglion cell layer, the RNFL, so nerve fibers, and then we have the internal limiting membrane. This is all the layers that we get from the OCT. You have to remember that the scan from the OCT does not correspond completely to the histological picture that we get. So there are some differences because this is reflectance, and we see different reflectance from accumulation of organelles, for example, which is not seen in the normal histology. Here, for example, you can see vitreous detachment. And here there is some vitreoschisis, which means that the vitreous has parts of it that are more have more water content, higher water content. This is an epiretinal membrane. This is very common, a very common condition where part of the vitreous remains attached to the retina and starts to pull on it and can lead to these abnormal contours, so folds in the retina, and also this reduces vision. It causes something we call metamorphopsias, which means the patients see objects, for example, not as a straight line, but as a curved line, and it changes the shape of the objects the person sees. And here we have an epiretinal membrane that has caused a hole in the macula, which is very bad for visual acuity. So when it's complete, usually the patient does not have central vision, which is very bad for their quality of life. But what we can do is operate, so surgical treatment of this. We can peel it off, this membrane, and then the retina begins to normalize its contour. And another very, very specialized method that we use in ophthalmology, this is the electroretinography. This is a method that gives us the electrical activity from the cells in the retina when they are stimulated by a flash of light. We have the classical ERG has 3 waves, so wave A, which is negative, and this is the response of the photoreceptors. We have the B wave, which is the response of the second order bipolar cells in the neurotransduction, and also the Muller cells, which are the supportive cells of the retina. And we have the C wave, which is also positive, and most scientists consider it's a function of the pigment epithelium, and it represents only rot signals. So, do you know which is the third neuron in the retina?
Ganglion cells?
Yes, of course. Very well. So the ERG does not give us information about the ganglion cells and the nerve fiber layer. So when we have damage to those, we do not have indications for ERG. So here is the normal looking curve of the ERG. We have the negative A wave, the positive B wave, and then the C wave. Some authors report a D wave, which is a slight depression after the C wave. But this is not that important, because we usually, what we do is we use multifocal ERG, and it sums all the responses from the retina to give us a picture if whether some of the neurons have lost function. So we have normal ERG, negative, subnormal. These are types of pathological ERGs. I will show in the seminar in more detail the different diseases that we use the ERG for. This is how it looks. We have chin rest for the patient, and the patient looks at the screen. We have different types of electrodes. Let me just change it a little bit. So we have contact lenses and electrodes that are fixed on the temple or inside the conjunctival sac inferior fornix. Usually we do the ones with the inferior fornix because it's easier and they are more available. So the patient rests their head and looks at the screen. We start the investigation, and the screen shows flashes of light in front of the eye, both eyes open. Usually we do it after a period of dark adaptation, so we get the rot response. And you can also do it in light adaptation to get cone response. The major indication for ERG is pigmentary retinitis, which is an inherited disease and usually leads to loss of peripheral vision because it's a rot disease. It's a disease of the rot system. So we do not have peripheral vision, and usually they have night blindness. They also have other changes in their eye. They are slightly myopic. They have early cataracts, and usually the final visual acuity is around maybe 0.01 in decimal visual acuity. What is known now is that there are a lot of genetic mutations that lead to this disease. But people right now are working on genetic treatments for at least some of the mutations, and that is why this is very important to get the treatment before the function of the retina is completely lost. Of course, this is still in clinical trials, especially in the USA. We do not have access to those yet, but hopefully in some years we will have some kind of genetic treatment for this disease. What other diseases we can assess with ERG? Some other inherited diseases, like for example Stargardt disease, also congenital stationary night blindness, which is similar to pigmentary retinitis, but it's stationary and it has a better prognosis. Also in retinal detachments, this is more for prognosis. So for prognosis, all the occlusions of the arterial and venous vessels in the eye. So also in inflammatory diseases like chorioretinitis, retinopathies. Of course, in macular degeneration, there was a research here that we did a few years back that we used ERG to assess the macular function before and after treatment with anti-VEGF medication. And also in cases of long-standing intraocular foreign bodies, especially if they are metallic foreign bodies, and if they persist in the eye too long, the retina, they become toxic to the retina because they dissolve. Pharmacotherapy in eye diseases. So we have a few methods of application in the eye. Of course, the systemic route is clear. I will show in the seminar what the blood ocular barriers are, because in the eye we have a lot of barriers to the blood, and most of the structures of the eye are isolated from the general blood flow, because otherwise we would get an immunological reaction. For example, this is the lens, this is the retina. It has several barriers, and also these barriers push out fluid that comes in the eye. So let's talk about topically applied drugs. We use them to influence the ocular surface, which comprises cornea, conjunctiva, and we hope that some part of the our drugs passes to the anterior chamber. Also, in cases, for example, of glaucoma, we use topical medication to lower intraocular pressure, so they pass through the episcleral veins towards the ciliary body where their action is needed. It's very important to assess the ocular surface in order to choose the right medication and the form of the medication. So either ointment or drops or some gel or something like that. So here are the hemato-ocular barriers. This is the walls of the blood vessels and the anterior chamber fluid. We have an internal blood retinal barrier, which is made possible by the structure of the walls of the retinal vessels. So the endothelium has tight junctions between the cells. Also around the vessels there are very specialized type of cells which are called pericytes, and also there is glial tissue around the retinal vessels, and all of these three make the wall of the retinal vessel impermeable to passage of blood components. The external blood retinal barrier is the so it's the pigment epithelium. It stops blood from the choriocapillaries to enter the retina, and also it provides a way back from the retina to the choriocapillaries, because the retina is supplied in the outer third from the choriocapillaries. The capillaries of the choroid, they are fenestrated, so they are not a barrier to blood, and they are permeable to blood components, serum components, and so on. And that's why we have the pigment epithelium to stop this from entering the retina. What are the barriers to our drugs? This is the corneal epithelium and stroma. So the cornea is very thick, and it has very strange water composition. So we have to keep in mind what concentration and what kind of medication we use, so that they can pass through the tear film, through the epithelium during the entire life of a person. And when it gets a little bit thicker and we have a smaller angle, then with age the angle becomes more and more closed, and then if we put drops in, then we get the acute angle closure. But this actually happens not at the time of complete mydriasis, but when the pupil starts to constrict and it is blocked in mid-mydriasis, and the eye becomes painful and needs urgent treatment, because the vision is very dramatically reduced and could become irreversible. Miotics. So how do we constrict the pupil? Usually we use pilocarpine drops. It acts predominantly on the muscarinic receptors. It's resistant to acetylcholinesterase. It crosses the blood-brain barrier. which can cause some side effects, and also it can cause xerostomia, which is as you know, a decreased secretion of saliva, and can cause a little bit discomfort to our patient. What are the drugs for glaucoma? This is very important because glaucoma is quite this is the most common reason for irreversible vision loss worldwide. So we have several drugs that have different mechanisms of action. What does decrease the production? First, these were the drugs that were used with the start of beta blockers. Beta blockers were the first class of medication after pilocarpine, which we said constricts the pupil. They cause decreased aqueous production, and you can see timolol, betaxolol. There are others, but we usually prefer timolol. It's very important to ask your patient if they use systemic beta blockers, because this will lower the action of the topical treatment because of downregulation of receptors. The second drug that came into action for glaucoma are the carbonic anhydrase inhibitors, dorzolamide, brinzolamide, acetazolamide. Topical, we have dorzolamide and brinzolamide. As lately they say that brinzolamide is a little bit superior with less side effects and more pronounced decrease of intraocular pressure. A very interesting category of drugs for glaucoma are the alpha agonists, so brimonidine and apraclonidine. Brimonidine is superior. It has lower side effects, but also it acts not only by decreasing aqueous production, but also it increases to some extent the uveoscleral outflow. And there are speculations that they have also neuroprotective mechanism of action, so they protect the ganglion cells from apoptosis. But this is it's still it's a speculation. It's not proven beyond a reasonable doubt. And the latest developments, maybe in the last 15 to 20 years, are the prostaglandin analogs. These are latanoprost, bimatoprost, tacloprost. All of these, they increase the uveoscleral outflow. They have better effect on lowering IOP than any other of the previous medications, and that's why we use them as a first line of treatment in glaucoma. And as we said, pilocarpine, this is used usually in angle closure glaucoma in order to keep the pupil from dilating and blocking the route from posterior chamber to anterior chamber. You will talk about this in detail when you get to the glaucoma. But also, how do pilocarpine increase trabecular outflow? It causes a constriction of the ciliary muscle, which pulls on the Schlemm's canal connection to the sclera, and that's why the Schlemm's canal becomes wider and more able to get outflow from the trabecular meshwork. So it has two mechanisms of achieving lower intraocular pressure. As we said, these are the prostaglandin analogs. What are the side effects of these? They're quite common. They cause conjunctival redness. They can cause allergic reactions. They cause dry eye, which is very affects patients negatively. It causes iris and periocular pigmentation, so the irises sometimes become darker. If a patient, for example, is with blue eyes and starts putting drops in, they can get brown eyes. And also they can get pigmentation of the eyelids, and a very good, I would say, a side effect is that we have hypertrichosis, which means eyelashes become longer and thicker. And actually, there are prostaglandins that are used in cosmesis to make people with lack of eyelashes to get thick and long eyelashes. The carbonic anhydrase inhibitors, as we said, we have the systemic one, acetazolamide, and the topical ones. They reduce the formation of aqueous humor. The side effects include paresthesia, a little bit more frequent urination because they cause excretion in the kidneys, and also they lead to hypokalemia, which is important, especially in patients with heart disease. But this is more common with the systemic application. As we said, beta blockers, timolol is the most commonly used. What they cause are irritation of the ocular surface. So all anti-glaucoma medications can cause dry eye and some kind of ocular surface disease because most of them have preservatives, like they are very toxic to the ocular surface. But nowadays the direction is to create eye drops for glaucoma that are preservative free, very important for the comfort of the patient and for patient compliance, because sometimes patients stop their eye medication because they cannot take the dry eye symptoms. So in beta blockers we can have headache. Sometimes they cause iris cysts and follicular conjunctivitis. This is a toxic reaction, and systemic side effects, for example, bradycardia, increased sweating, anxiety, and also nightmares. So these are the typical side effects. They are not so common, but they are possible. The hyperosmotic drugs for glaucoma, as I said, these are used when the IOP is very high. We have glycerin and mannitol and some others, but we usually use mannitol. Glycerin is a little bit more, has more side effects that are uncomfortable. We have fixed combinations. Usually they include the beta blocker with some kind of other medication. We have fixed combinations of prostaglandins and beta blockers, alpha and beta blockers, alpha agonists and beta blockers, and carbonic anhydrase inhibitors with beta blockers. All kinds of combinations are hitting the market every day because it provides better compliance, because the patient has, for example, one bottle that combines two drops, and they are more willing to put in only one drop. And of course, it reduces the toxic effect of two bottles. So we need anti-inflammatory drugs in ophthalmology. The first and most important group are the corticosteroids. We have topical, local, systemic, whatever you want. We use them in any kind of form we can get. Non-steroidal anti-inflammatory drugs, also we use them as topical and systemic application. So this is a classification of the steroids. So we have short-acting, which are hydrocortisone, one of the, I would say, with less side effects, cortisone, prednisolone. These are the short-acting. Intermediate are the triamcinolone, which we use a lot, especially in intravitreal injections. And the long-acting are the dexamethasone and betamethasone. What are the indications? For topical corticosteroids, we have all kinds of allergic reactions on the ocular surface, inflammation of the sclera, of the uvea. On the cornea, we can have changes from allergies, and of course, always after intraocular and extraocular surgery. We have topical ointments that we use for diseases of the eyelids, for example, for chalasia. We use creams, we use gels. This is to improve the condition of the ocular surface. We had a patient yesterday that was operated around 10 days ago, and she complained of severe redness and pain in the operated eye. And when I checked her eye, I saw that she had intraocular inflammation. And I asked, did you put both drops in? Yeah, of course, I put both drops in. And I said, yeah, you will have to continue because you have intraocular inflammation. And I was getting to do a peripulpar injection when a colleague of mine asked her again about the drops, and she said, no, I just put one type of drop, the other one I didn't open. And actually what we found out is that she didn't put her steroid drops in, and she only put antibiotics in, and that led to intraocular inflammation. Fortunately, she is okay today because she started a little bit more intensively putting the corticosteroid drops in. So these are very important in the peri-surgical period. The systemic steroids, usually we use them for inflammatory diseases, for uveitis. Sometimes we combine antibiotics and corticosteroids when we have infectious uveitis, because the inflammation of the posterior part of the uvea is usually comprises some kind of autoimmune reaction. For optic neuritis, when we have an inflammation of the optic nerve, this is very common in young women with multiple sclerosis. Then we have to use a lot of corticosteroids. And this is typically we use 1,000 milligrams per day for 3 days in order to improve the condition of the optic nerve. And for corneal graft rejection, we use all kinds of anything that we can get our hands on. So corticosteroid drops, injections, periocular injections, and also systemic, either intravenous or oral. So if you're suspecting infection, of course, you will not give steroids alone, at least. Also, you have to keep in mind that steroids lower immunity, and they also make the wound healing process longer. So you have to keep in mind that, for example, you can get an activation of a herpetic virus in the eye if you are not careful with steroids. Around a month ago, we had a patient that we didn't see for 2 years. He had some kind of corneal neovascularization, and he decided that he would put steroid drops for 2 years, and this led to melting of the cornea. So also be careful how long the people, you have to instruct your patient very well when to stop the steroid drops and how. Usually we stop them gradually, we taper them, and never from one go. So the side effects of steroids are quite bad. In the eyes, corticosteroids can lead to increased intraocular pressure, which is glaucoma. They can lead to cataract formation. They can lead to activation of infection. As I said, they can lead to activation of herpes, or they can lead to tuberculosis as well. So this is important to keep in mind. Systemic side effects, you know them probably better than me, but you have peptic ulcers. So when you prescribe systemic steroids, you have to have some kind of PPI. For the side effects, hypertension, so control of the blood pressure, control of the blood sugar, control of for osteoporosis, we usually give our patients some kind of calcium with vitamin D. They can also have mental changes, and really careful with tuberculosis, which is not that rare. Non-steroidal anti-inflammatory drugs, we use them either topical or systemic, but topical we have diclofenac, naproxen, ibuprofen, and so on and so on. What are the indications? Usually when we have some kind of autoimmune inflammation, for example in episcleritis and scleritis, they are usually connected with seronegative spondyloarthropathies, Bechterew disease, reactive arthritis, and so on. These can also cause uveitis. In cystoid macular edema, this is let's say complementary to the intraocular injections, but we have very good results with people that put in NSAIDs for 3 months, and then the edema is mostly gone. And sometimes we can spare someone from the intravitreal injection. Also, preoperatively, some people use them preoperatively to maintain dilation of the pupil. Antibacterial drugs, we have a lot of antibiotics. Sadly, we have a lot of resistance too, but usually we use all types of antibiotics, all kinds of groups. Most commonly used are the fluoroquinolones. They are a little bit, there are newer generations, aminoglycosides and macrolides. Vancomycin we use when we have severe infections. We use it for intravitreal and intracameral injections, and flush of the anterior chamber with vancomycin. Topically, we can use them preoperatively and postoperatively as prophylaxis. We can use them orally when we have a severe inflammation of the orbit. For example, we use third generation cephalosporins or something we have in our clinic. Intravenously, we use them when the inflammation of the orbit is behind the septum, so orbital cellulitis. I think you had already this lecture about cellulitis, that there is preseptal when it's only in the eyelids, and orbital when it's behind the septum. This is a very severe infection with a high risk of complications such as venous sinus thrombosis, and actually it's life-threatening. What I wanted to say, we use oral antibiotics for treating infection of the nasociliary duct as well, because I had maybe in the last month 4 or 5 cases which are very dramatic. They get a very serious inflammation, and they can also get orbital cellulitis. It's very close to the orbit and very close to the brain. So it's important to give orally, at least orally, antibiotic to prevent further complications. So we have tetracyclines, macrolides, azithromycin, erythromycin, and so on. And as I said, the most commonly 14-1s. Chlamydia infections. We have this disease, Homa, which is not common in Bulgaria anymore, but in warm climates it's a big problem. It causes conjunctivitis, it causes inclusion conjunctivitis, it can cause scarring of the cornea. Penicillin is a deficit, a very great deficit, and also we use penicillin to treat syphilis, which is also very common apparently, but there is no penicillin right now. So we use anything else that we can find data that it's effective. So cephalosporins, gram-positive cocci, second generation, third generation, and we have to be aware of allergic reactions. Whenever we use systemic antibiotics, we make probes for allergies. So we make a scarification on the arm, for example, then we put in some drops of the antibiotic, and then in a few minutes we estimate if there is allergic reaction or not, and then we are safe to continue with our intravenous application of the antibiotic. Gentamicin, I want to say that gentamicin is the most effective to this day eye drop for bacterial ulcers and bacterial infections as a whole. But we do not use it that often because we do not want to get a lot of resistance to it. It's reserved for more severe infections. Tobramycin is also one of the most commonly used antibiotics. Usually we use it in combination with dexamethasone. Tobradex you probably have heard and probably have put in your eyes. This is for anything from halacia to ulcers and so on. Since we are getting pressed by time, I'm not gonna stop and talk about each and one of them. I just want to say that when you prescribe an antibiotic, topical or otherwise, you have to instruct your patient to put the drops, for example, are 4 times a day, at least 7 days. We have a lot of patients that just decided to put some kind of antibiotic. Yeah, I did put it like 3 times a day for 3 days, and then I stopped. This is wrong. This creates resistance. So you have to instruct your patients exactly how to put the drops in. We have azithromycin topical, which is twice a day if your patient does not want to put 4 times a day drops. And we have to talk about antiviral drugs as well, because herpes is really common in the eye. It causes a lot of problems. We have acyclovir, valacyclovir. So we have topical ointments usually, which we have acyclovir, which is really easy to get, and we also have ganciclovir, which is we usually order it specifically. Just I want to go back to the antibiotics. I want to say something about the cornea and doxycycline, which is a very good antibiotic in my experience. If you have a diseased cornea, either from bacterial infection or some kind of melting of the stroma, doxycycline blocks collagenase, and if you give it orally, you can block the collagenase enough so that you prevent further corneal melting and also slow down the bacterial infection. So back to the antiviral drugs. So we have a lot of viruses. We have acyclovir, valacyclovir. We have foscarnet and also valganciclovir. There are a lot of antivirals for herpes. Usually, we hope that acyclovir will help. But if acyclovir does not help, which is the typical dose of acyclovir is 5 times 800 milligrams, so 2 tablets, which is a little bit uncomfortable for the patient. And that's why we have valacyclovir, which we give, it's 500 milligrams, and we can give it either 2 times a day, 1 tablet, or up to 3 times a day, 2 tablets, which is a little bit easier to keep up with, and has more better compliance. As I said, acyclovir, one of the most commonly used, 5 times a day. We have the ointment. The ointment should be discontinued after the maximum of 14 days because then it becomes toxic. And you cannot say if the herpes is still active or you have a toxic reaction to acyclovir. We have, as I said, Virgan, which is ganciclovir for topical treatment. It's also an ointment. It's a little bit better. I think it has less toxicity. There are other variants for antivirals. And the indications are keratitis and uveitis. I had a patient which had cytomegalovirus retinitis, which is a very terrible condition and leads to blindness. And somehow she found valganciclovir from abroad. And actually she gained vision in this eye, which was almost lost. And that is why we have to use antivirals whenever possible and the best possible option. So we have, as I said, valacyclovir, pharmaciclovir, continue foscarnet, ganciclovir, valganciclovir, and cidofovir. Usually cytomegalovirus infections are seen in immunosuppressed patients and especially in HIV patients, and they need these special anti-herpetic drugs. Antifungal agents, because we have unfortunately fungal infections of the eye. These include amphotericin, fluconazole, voriconazole. We do not have a trademark for voriconazole, but we have a way of mixing it in from some pharmacies. They mix it up for topical use, and its effectiveness is great. What are the indications? Fungal corneal ulcers and fungal endophthalmitis usually. Fungal retinitis is quite rare. So I'm not going to stop too much for the fungal. We have a lot of research on this matter because most fungi are very resistant to any kind of treatment, but actually some more bold colleagues have started injecting the drug inside the corneal stroma with very good results. The other option, if you have a fungal keratitis, is to do a corneal transplantation and hope that the patient does not reject the transplant and fungi do not repopulate the transplant as well. So dry eye, this is something that is very common disease, and also especially in these days when most people work from home in front of the screen. When we are in front of the screen, we forget to blink, and the ocular surface becomes damaged and dry, and tear film starts to be unstable. It breaks, and so on and so on. This leads to chronic inflammation with change in osmolarity, with change in some inflammatory molecules. It's a very complex disease, and it lowers quality of life a lot. So we have the lipid layer from mostly from the meibomian glands. We have the aqueous layer, which is from the lacrimal gland and accessory lacrimal glands in the conjunctiva. It's also a way to feed the cornea because the cornea is avascular. We have the mucin layer, which helps to connect the water-soluble aqueous layer to the lipid cellular surface of the epithelium, and this also provides a smooth surface and less diffraction of the light. The mucin layer is secreted by goblet cells in the conjunctiva, and then we have the cornea. It's important to know that the tear film actually is part of the optical system of the eye. If we do not have a tear film, the uneven surface of the corneal epithelium would lead to diffraction of light, and then we would never get a clear image on the retina. What are the treatment options? We have artificial tears, one of the most commonly used medications. We have ointments. We have anti-inflammatory medication. As I said, this is a chronic inflammation, and also immunomodulation. I will talk in the seminar more about artificial tears. This is the macular degeneration. We have to talk about anti-VEGF drugs. I think I used the same picture in my presentation as Professor Oscar. So this is the wet form when we get new vessels and bleeding and then scarification, and the dry macular degeneration when we get these deposits between the pigment epithelium and the Brooks membrane. They are called drusen, and when in the attempt of the eye to remove them, in their place remains atrophy, which when it comes together, it's called geographic atrophy. And as you can see here, sorry, let me just move it a little bit. As you can see here, we have no photoreceptors, no pigment epithelium. This is complete atrophy of the outer retinal layers. When you have wet AMD, you have subretinal hemorrhages or all kinds of hemorrhages. You have accumulation of water-soluble components here, and so on. So how do we treat the wet AMD? Because the dry AMD, for now, we cannot treat effectively as for the visual acuity. We have anti-VEGF. VEGF is vascular endothelial growth factor, and it's responsible for all new vessels in the body. It's usually it's very important during fetal development, but it's also involved in this disease, AMD, and also in some tumor developments. It is responsible for creating new vessels for tumors. This is how the treatment was actually found. Avastin, bevacizumab, was created for treating colorectal carcinoma. in order to prevent new vessels from growing and then reduce the size of the tumor. After that, people found out that actually it influences macular degeneration. They started by intravenous treatments, and then someone said, why not inject it directly in the vitreous? And that's how actually the whole era of the anti-VEGF medication started. Nowadays we have a lot of different options, but the most recent is aflibercept. We have either VEGF traps or antibodies. So these that are bevacizumab, this monoclonal antibody. This is antibody against the VEGF molecule, which has several different subtypes, and not all of the antibodies are work against all of the isoforms of VEGF. That's why they created the VEGF traps, which actually broke the receptors, which is better. And also currently people are working on creating a genetic treatment that would make some cells secrete anti-VEGF inside the eye. So a little bit of questions. When do we not use OCT? So for macular degeneration, do we use OCT? Okay. So we cannot use OCT for cysts of the ciliary body because they are behind non-transparent ocular structures, which is the sclera. OCT cannot pass through the sclera, and that's why we cannot see the ciliary body. If we have a intraocular foreign body after a trauma and we suspect we have blood in the vitreous and retinal detachment, what method would we use?
See?
Metallic intraocular foreign body.
B ultrasound.
Yeah. Okay.
On a camera.
If you have to remember that if you suspect a metallic intraocular foreign body, you cannot do an MRI. You can do a CT. We do CTs because sometimes there is more than one foreign body, not one in the eye, but one in the orbit. And that's why ultrasound will give us the location of the foreign body in the eye, as well as it will tell us if we have retinal detachment and blood in the vitreous. What phases does the fluorescein and geography have? Which is the correct answer? This is except
Diastolic.
Yeah, diastolic. Yeah, this is a very simple question. Okay, so can we have 20 minutes recess before we start with the